Welcome, everyone. This is our second day of our third Ontario West Midwifery Conference. And we're really excited today is the theme of the day is advancing innovative clinical programs. And this day is typically, we receive pretty good feedback, pretty outstanding feedback every year. So we're really excited to bring you some more really wonderful things midwives are doing all over the province. My name is Megan Furnival, so I'm the research lead for the Department of Midwifery at LHSC. I'll be your host for today, and I'm really grateful for the time the presenters have set aside today to share their creativity and their experiences with innovating and building something new in their communities. I think many of us have big ideas about what the world could look like, but the presenters today are busy taking steps and action towards creating those visions. So we want to start off really quickly with a land acknowledgement. So we acknowledge that this sacred here in London, this sacred land upon which we are privileged to live and work, we have a deep connection and a longstanding relationship between Indigenous peoples in the land of southwestern Ontario and of London. This land has supported human beings for at least the past 10,000 years and is the traditional territory of the Anishinaabeg, which includes the Ojibwe and the Chippewa or the Chippewa Nation, the Haudenosaunee, which is also known as the Iroquois, which includes the Oneida Nation, and the Attawandaron, which is also known as the Neutral, and the Wendat, so the Huron peoples. We're deeply grateful to have the opportunity to be in this place, and we acknowledge that this is really just the beginning of a process, and we commit to a continued journey of listening, learning, and building relationships to find truth and reconciliation, and collaborating on 3 major projects that the Indigenous midwives stated would improve their ability to provide culturally appropriate care, and as well to be incorporated into the hospital environment as per the Truth and Reconciliations Commission's calls to action number 22 and 23. So before we start, I just want to really briefly go over some small housekeeping notes. All the presenters' Zoom audio and video should remain off during the presentation, participants, so that we can save on the live feed. All presentations are going to be recorded, so we will have them up on our website for everybody to view afterwards. At the end of the speaker's presentation, there'll be time permitted, about 5 to 10 minutes for questions. Please type any of your questions in the Zoom Q&A box. If we have issues with the Zoom Q&A box, you can put them into the chat, but the Q&A box will be where we look first. I'll turn on my video with about 1 minute remaining just to let the presenters know that it'll be time to finish up shortly. In order to be respectful of all the presenters and the panelists' time, we're gonna do that just so that we can make sure everybody has an opportunity to give their full presentation. We will briefly introduce our speakers, but we'll put the bios in the chat just to save time for the presenters in their presentation. And we really, really welcome feedback at the end of the conference. We'll have a QR code posted with a very quick feedback survey that helps inform next year's conference planning. And then finally, everyone will get a certificate of attendance in the coming weeks just to indicate the participation. So let's get started on the amazing talks that we're going to hear today. So for today's first presentation, we have Lauren Columbus. Lauren is graciously filling in for Harriet Deborah, who had a last-minute conflict arise, but Harriet has put significant amounts of work into this study already. So we'll be sharing both Harriet and Lauren's bios in the chat. And Lauren's talk today is titled An Evaluation of the Time Expanded Midwifery Care Model Using the Re-AIM Framework. So Lauren, when you're ready, you can go ahead and start your presentation.
Perfect. Thanks so much, Meg. I really appreciate it. And yes, I wish Harriet could be the one here today sharing her work. She is a McMaster Midwifery Master student who's been part of the time evaluation. And I know she would have loved to have present today. I just also want to thank our study team, which is a very excellent, robust interprofessional study team. We have Dr. Beth Marie Davis and Julia Simeone from MAC who are supporting us here. And we also have Dr. Banner from MFM, Erica, who's one of the midwives who works in the time program, and Alice, our medical student who's helping out. This is pretty necessary for a large scale evaluation. So I just want to thank all of them as well. And speaking of resources, I want to thank the Children's Health Foundation and London Health Sciences Centre for funding LHSC's limited term research chair in midwifery. This is a first in Canada and a very unique model that our hospital has sort of graciously funded us for. It supports Dr. Beth Murray Davis in her role as our limited term research chair, which means we are able to conduct all of this midwifery focus and midwifery led research, including the evaluation of this project and this program. So as many of you know, any sort of large scale, significant program evaluation of this type takes a lot of resources and a lot of time and requires funding to fund those positions and that work. And so we're really grateful that we get to be able to do that. However, our goal for this project is obviously to have this be an REB approved study that we can ultimately publish and send out into the universe. And so if that's not the goal for your program evaluation, then there are ways to approach this framework and your program evaluation in a way that's a little bit more sort of pragmatic and maybe less resource intensive. So we'll go through that today. In terms of a quick background for the TIME program, we presented on this program before at this conference and elsewhere, but to catch everybody up, the TIME program was launched by the Department of Midwifery at London Health Sciences Centre in October 2022. So we've just hit our 2-year mark. This was funded through the Ministry of Health Expanded Midwifery Care Model, or EMCM funding. You're probably going to hear that word a lot today. This is funding that permits midwives to work in sort of non-billable course of care or non-caseload midwifery settings. It symbolizes an innovative partnership between our maternal fetal medicine specialists and midwives, where we focus on high-risk pregnancies. And the goal of the program was to provide really comprehensive prenatal and postpartum care. It doesn't involve intrapartum care aside from attending booked cesarean sections. To this high-risk MFM population. We know that this population is disproportionately impacted by social determinants of health, and that they generally have worse experiences navigating the healthcare system, and that they tend to also use more resources in the postpartum, like the emergency room, triage, both for themselves and their newborns. And so the goal is really to be able to provide comprehensive, excellent care and education to this population, with the hopes of giving them both a better experience as well as reducing the cost to the healthcare system. When we took on the goal to evaluate this program, obviously our goal is to make sure that the program is meeting its intended goals and that we're doing it the way that we're supposed to be doing it. So that means to holistically describe the population that TIME serves, analyze the care we're providing, assessing the clinical outcomes, and understanding the comprehensive impact that this program has. We also want to look at the perceptions and the experiences of the healthcare providers that are working in this program, both our interprofessional colleagues as well as the midwives and the patients who are benefiting from the care. However, if we step it back a little bit, we had a bit of a larger goal as well, and that what the study team wants is to have sort of peer-reviewed, formally published literature that's out there, as I said, in the universe, supporting the work that is happening in these innovative care models. And so that was really kind of the primary goal, because once this is out there and published, then it means that there's literature that policymakers and hospitals can refer to in terms of deciding where they put their healthcare dollars. And how they form programs and who gets to be part of those programs. So we really believe that doing these types of evaluations of new innovative programs is important. But I just want to add for today that for those of you who work in MPG caseload models, this will be just as important for you to look at the work that you do within your midwifery practice group as well. This is from the REAIM website, and so I can't take credit for it, but it's following the concept that many of us employ fairly standard patient feedback surveys in our practice. It's something that most midwifery groups do, and we as well integrated this into the TIME program from our inception. We had a standard patient feedback form, and most of the feedback we get is sort of glowing reviews from patients who are absolutely thrilled with the care they receive. And I think for many people, that's probably enough, to say our patients are happy, so we're happy and let's carry on. But what the REAIM framework points out is that, even if a program is 100% effective, it's only really as good and in terms of how widely it's adopted, whether people are actually delivering it and implementing it as it was intended to be implemented, that the targeted populations are the ones who actually receive the care. And maybe most critically, especially in this sort of current landscape of midwifery in Ontario, is that it's sustainable. And so they sort of make the argument that if a program, is really 100% effective, but it reaches nobody, does it have any impact? And I think the same thing can be asked of our the way that we work and the way that we're planning and implementing and designing EMCMs and innovative care models in midwifery, is that if we're not actually able to keep them going or bring them to the right populations, then as you sort of multiply all of these aspects of the framework, the overall impact actually is quite small. So that's sort of the justification behind using this type of framework when evaluating what could be considered a public health initiative. So the REAIM framework here consists of these 5 domains that you can see listed. And the reaim.org website is excellent. They have all of these tools available for free. It's a very approachable framework to use, very accessible. So I put the QR code up there if you'd like to take a look at it. They use both pragmatic language, which is shown here on this slide, as well as more technical or research-based language, if that's the route you're going to go. But when they're looking at these 5 domains, we have the reach, the effectiveness, the adoption, the implementation, and the maintenance of a program. Using pragmatic language, they look at who, what, where, how, when, and why for how the program is being delivered. And so if you look at the reach aspect here, we're looking at who the program was intended to benefit and who actually gets to participate in it. The effectiveness would be what's the most important benefit you're trying to achieve, and did you achieve it, and what is the likelihood of possible negative outcomes. The adoption, implementation, and maintenance are often the things that we overlook when we're implementing a program, and that would be things like where was the intervention applied, who applied it. For implementation, we're looking at how consistently was your intervention actually delivered. How can it be adapted? How much did it cost? And why did those results come about? So can you be sure that you're attributing the results that you're seeing to the actual program, or what parts of the program are those attributable to? And lastly, for maintenance, when did the program become operational? How long can you sustain it? And how long can the results from the program be sustained as well? So it was using this sort of aspect of these aspects of the REAIM framework that we then looked at it in terms of our own program. So for this slide, I'm going to walk through how we applied it to the time program goals and sort of outcomes. But as I'm going through this, feel free to sort of think of it how you might apply it to your own program or in your own clinical setting. So when we looked at the different assessments and measurements as far as reach was considered, we were really, one is fairly basic. We were just looking at, what are the sort of numbers that we were able to reach? How many visits were we doing, postpartum, prenatal, how many infants were in care, et cetera. But in terms of the proportion of the time program patients that fell within our actual targeted demographic, we really will have to conduct a retrospective chart review of antenatals to make sure that the people that we were taking into care actually met our criteria. So this would be things like history of mental health concerns and bereaved families, people who generally have difficulty navigating the healthcare system, like newcomers to Canada, racialized folks, marginalized populations. So that's a really important piece of this evaluation. In terms of the effectiveness, we're looking at the impact that the time program would have on certain selected clinical outcomes, as well as any potential negative outcomes. This can be challenging to do when our role is not in an intrapartum setting. And so we want to make sure that whatever clinical outcomes we're looking at are actually from the impact of having the time program involved. Many of our patients, they already have extremely complex medical care plans. And so oftentimes, their actual clinical outcomes from their birth could not really be attributable to the work of time. This is quite different from an MPG setting where I think your clinical outcomes like, mode of delivery, cesarean section rate, transfer of care rate, those are very much attributable to the intrapartum care that's provided. So we had to really kind of think about what we wanted these metrics to be. However, another kind of goal of the program was that the patients would have a better experience within the healthcare system. And so to measure that, we actually have to move outside of some of the typical quantitative measurements and look at qualitative measurements instead. And something that the REAIM framework has done, which was sort of first published in 1999, has been to really emphasize the need for more qualitative data being used within the framework. And that was to look at, patient satisfaction, patient experience, provider experience, and even experiences from people like administrators within the hospital, managers, directors, in terms of how the program was adopted and implemented. So we will be using interviews, semi-structured interviews with patients to look at the patient satisfaction aspect and whether they're actually getting out of the program what was intended. The adoption aspect looks at how many care members within the organization and team are collaborating and working with this program. So we'd be looking at things like the number of healthcare providers who are referring to us. Is the antenatal nurse referring to us? Are the social workers, flagging patients as well to be referred to our program? How much is this being adopted by our interprofessional colleagues? We would also similarly use semi-structured interviews to look at the perceptions of healthcare providers about the program's impact on, the way they work, the way their clinics run and function within the hospital, and their perceptions of the care experience as well. In terms of implementation, we're really looking at whether the time program has been implemented as intended. What does it cost? How will it be adapted going forward? And so we'd be looking at some sort of basic numbers, like are we able to function within our budget parameters, but also looking at perceptions of healthcare providers around the program fidelity. So again, if we go back to your patient population target, if you designed a program to access a certain portion of the population, and you in fact are not accessing it, then what you're doing is you're not rolling out the program as it was intended to be, and you've sort of lost fidelity to your program. So a lot of that is really important, and I think it's probably the piece that's missed the most often. And lastly, for the maintenance and sustainability, we're really looking at how the program can be institutionalized within LHSC and the impact that this has on patients both at 6 weeks postpartum as well as 6 months postpartum. So are any of the sort of benefits maintained, sustained for this population? So this also involves interviewing people who work in the time program to find out, like, is this a role that is sustainable? And again, I think this is a huge question in Ontario midwifery right now in general. And I think this is a question that a lot of the midwifery practice groups could ask themselves as well. If you have a lot of turnover in your practice, or you're struggling to sort of keep midwives within your group, you may have to look at the sustainability of whatever model it is that you're working within, call models, caseload, things like that. And the same would apply to the EMCMs and employee model type of midwifery clinics. All right, so I'm just going to pop over to our mixed method study design here. So as I mentioned, we have a mix of quantitative and qualitative data. This is very necessary to fill out all of the components of the REAIM framework that we are hoping to measure. Harriet pulled a few of the very preliminary findings from her healthcare provider interviews. And I just pointed out in terms of some of the themes that she's starting to recognize within her interviews, sort of where they might fall. So for example, the healthcare providers that she interviewed noted that there was increased support for breast and chest feeding, and that was impacting the success that their patients had with that type of infant feeding. So that would fall under the effectiveness category. So we just sort of are making sure that as we're going through these, we're coding them in terms of which aspect of the outcomes framework we're looking at. So I'm just going to wrap up now. We're going to have obviously more data when this project is complete, especially as our quantitative phase launches. So I'm sure you'll see me back here next year with the results from this study. But I just want to reemphasize that REAIM is an outcomes framework that can be used by researchers and non-researchers for all of the important aspects of planning, implementing, and evaluating a program. And lastly, that we really have I've approached this with a quality improvement heart, in that we feel very passionately that the patients of this program deserve to have the most optimized and best care that they can get out of this program, and that it's actually our responsibility as people receiving this money from taxpayers to deliver this in the best way possible. So that's the goal. And yeah, thank you so much, and I'm happy to take any questions.
Wonderful. Thanks, Lauren. It's so interesting watching like each person talk about the work that they're doing and how much overlap exists just looking at the findings of like the continuity of care study and how you had such a high satisfaction level. BCC models have such a high satisfaction level, but then there's always the question of, how sustainable is it within the profession? So I love that I love that you're capturing both the clinician perspective and the provider or the patient perspective. We do have some time for some questions, so feel free to add any questions to the Q&A if you have any. I was going to ask you, Lauren, just while we're waiting to see if anything comes through. I was going to say really quickly, what might be useful is a bit of a playbook when this is all over, how to do this in your own center, and what that kind of those steps would look like. But my question for you is, we have so many new EMCMs, but very few studies have evaluated their effectiveness. So can you just walk us through quickly what kinds of barriers there are to evaluating EMCMs outside of like capacity and money, I guess?
Yes, and I know we have a lot of people here today who work in EMCMs or maybe planning them or getting them going. And I think they could also speak in the chat too to any barriers that they've seen with evaluating their own programs. But I think it's just time and resources to do it. So many of the people who are most passionate about their EMCMs are the ones who got them up and going and are working in them and really do not have time to take on this kind of an evaluation. So I think that's the biggest piece. And, collaborating with some of the researchers in midwifery out there in Ontario, I think is a great way to have that sort of clinical and research world come together to support the outcomes that we have. But I can appreciate how much work that this has already been just getting it started, let alone completing sort of the rest of the steps. So that is a reality. And I was joking to my husband about this presentation last night, and he said, "Oh, are you just going to tell people not to bother? It's too much work to do the evaluation." And yeah, it's a significant barrier to getting the research out there.
Absolutely. And Jenna and Jenny just posted in the chat, as well, both part of EMCMs. Jenna said data collection was a huge barrier early on because in 2018, they had no access to Born, so that they had to build all their own data collection processes within the EMR from scratch, which is a huge build.
Yeah.
So that I can totally appreciate. Jenny, I believe it's Jenny from Norwest. Correct me if I'm wrong, but I think the organizations that house the programs can also be facilitators or barriers to program evaluation, which is 100% correct.
Yeah, you have to have buy-in within your institution and organization to want to support it. Because even, for things like if we want to interview all of the healthcare providers, our interprofessional colleagues who may be, salaried nurse employees, social workers who are employees, MFMs, like they need support from their institution to take part in this. And so fortunately, we have a really supportive institution here for doing this evaluation. And I'm really grateful for that, but that's not necessarily the case everywhere.
Wonderful. Thank you so much. I know that I look forward to seeing how this all goes once we get all the data in. And again, being able to create something that might be replicable in other centers for other people.
Mhm.
It's always nice to package the work, the hard work, to make it easier for others that also want to do it. So
Absolutely.
thank you very much. So we
Thank
are going
you.
to move on to our next speaker, our next panel. Let me just make sure we're organized here. So we are moving on to our next group. So this will be a presentation from three separate EMCMs as well as the panel discussion that will follow. So the session is called Midwives and Collaborative Healthcare Partners Meeting Sexual and Reproductive Health Needs for Underserved Communities. So this session will involve, as I said, the presentation. There are shorter presentations, so feel free if you have questions after to put them in the Q&A. I have some questions for our panelists after that are specific questions, but I'm happy to trade some of mine for anything that the participants, the attendees want to ask as well. So our EMCM showcase is going to start with Rebecca Carson and Jill Parsons. Both work for the Community Access Midwifery Program through the Guelph Community Health Center. So if you want, whoever is going to share their slides, you're welcome to go ahead and do that. Just let's make sure we've made you a co-host, so you can go ahead now. And then after you will be Rebecca and Jenny, and then Jenna Bly will be the third presentation. And let me know if you have any issues.
Okay, it looks to me like it's working. Does that work for me?
Yeah, yeah,
Okay,
great.
perfect. Well, thanks so much for having us. We're really excited to be talking about our program and going through sort of the process, because I would say of the programs that are going to present on this panel, we're some of the newer we're the newer program, so we're going to go through a little bit about our program development process. So, and I'm Rebecca, and beside me is Jill. Sorry, I didn't put Jill's name in the login box there. So our program consists of 4 funded full-time equivalents. So it's myself, Jill, and Isomi who are working right now, and we have Emily Stewart-Wilson who is on leave, and we feel very lucky and grateful that we have this team of 4 engaged in doing this work.
And one of the things we want to address today is sort of how to build a program. Rebecca will be talking a little bit later on in how exactly we got here, but starting with identifying gaps in the services in your community and conducting a needs assessment, however that needs assessment might look, as well as engaging community members throughout the process to make sure that it is the community-based and community engaged project.
So our program has evolved over time, and it's really kind of coalesced into 2 kind of main separate and sometimes overlapping priority populations. So our 2 stated priority populations are individuals who are experiencing homelessness or insecure housing, experiencing poverty, using substances, or who have complex mental health. And in general, those are folks who we found typically we're just not able to access any existing pathways for care related to pregnancy or early parenting or reproductive care. And also recognized very early on in sort of the establishment of our program that there really are no specific services for folks who are newcomers, identify as racialized, and certainly an uninsured population as well. And so there was a lot of overlap in how we were building our program in terms of being able to meet needs for those communities, but obviously sometimes the needs are very divergent. And so really clarifying that we had these 2 distinct priority populations helped us to define what services we were going to offer and how we were going to build the program.
So the Guelph CHC camp team, the Campus Community Access Midwifery Program, works to meet the reproductive needs of people experiencing individual and systemic barriers in accessing our healthcare system. And as Rebecca mentioned, that sort of has sort of naturally seems to be these two groups. We aim to provide care that meets individuals where they are at, supports their autonomy and dignity, and provides culturally appropriate care. We aim to apply the principles of trauma-aware care, harm reduction, and anti-oppression in all aspects of our care. And we think very deliberately about how we work and how it is that we work hard enough to be like good enough providers. We tried to build a program that is client-centered as opposed to, provider-centered, and recognizing that one of the special skills that midwives have is in community-based care, which allows us to be flexible and innovative when it comes to systems, because we're familiar with both hospital-based and community-based care. We can be creative and find ways to meet the needs of the population, because we are also continually witnessing the barriers that our clients face, and trying to adjust the care so that we can both meet their needs, but also advocate for care, advocate for change, to address those barriers. And sometimes that just means witnessing it alongside the client and just saying, yes, that is a barrier, and we may not be able to make the change in the individual moment, but we'll do what we can moving forward.
So in terms of what work we do, and this has definitely evolved, we're building our program. Our team offers visits for any needs that are related to pregnancy and postpartum, up to 8 weeks after birth or 2 months. Our clients don't have to commit to coming in regularly to see us, so we do provide a fair bit of episodic care, and that's certainly how our program was born, was through episodic care primarily. We work with clients to really determine what care they need, and then we provide either a series of visits or sometimes just a one-off. So we do provide pregnancy testing, STI screening. We provide prenatal, interpartum, and postpartum care. The interpartum component of our program is relatively small. It's a small population that really needs camp attendance at labor and birth, and it's usually for our most complex clients, and we're working in collaboration with our obstetric or family medicine team members. We provide miscarriage care, assistance accessing pregnancy termination, a pregnancy checkup, prenatal education. So sometimes people just need one visit with us to have some prenatal education, make some decisions in their pregnancy. We do obviously home baby checks and home postpartum care for adults who aren't parenting. We do pap testing, sexual health counseling, contraception, IUD insertions. We're hoping to be offering Nexplanon in the next few months as well. So we really do see, we really have seen lots of little pockets develop in terms of what, and it varies over time, what services we've been providing most versus some things kind of wane and some things then build at certain points in the program.
The philosophy of care provision is really maintaining that we too are learners. And again, we've said this, but infusing harm reduction principles in the care we provide, aiming to provide culturally aware, sensitive care, and admitting when we don't know, and doing consultation when appropriate. We provide each other with networks of support, and we build networks of support for our clients as well when we can, and we have a lot of capacity for that being housed within the CHC. There are lots of providers and what are called social prescribing options at the CHC as well, so we can really start to provide some of that wraparound support for clients who become involved with us.
So in terms of our program creation, there were lots of gaps that we saw early on. We initially began as a hybrid model with both Schedule Q funding through Midwifery Practice Group, and we were doing caseload midwifery as well. We were funded through an EMCM in 2023 that's through Ontario Health. So we were among the first batch of EMCMs that were funded not through the Ontario Midwifery Program. And we've been a fully staffed program for the last 5 months. Yeah, so we're still very new in terms of what we're doing.
I see that we're running low on time, so I'll try and go through this quickly. What we've learned in terms of applying for the funding, when grant writing, using key phrases, matching up the application questions with very specific answers, thinking about, as was discussed in the earlier presentations, like think about evaluation frameworks in the beginning stages. Lots of interprofessional collaboration, and from a gap filling perspective, like trying not to duplicate services. There's a really great service through the CHC called Welcoming Streets, which is folks who go out when somebody's in crisis and try and de-escalate the situation. We're not going to necessarily take that on because that's being done really well by an existing team.
So, and I think in terms of evaluating our impact, which is kind of a theme, we had the great fortune of working with Toward Common Ground, which is a community-based nonprofit that really works around building social capacity in our community. And we had really 2 long coffee dates with them. And they really were helpful. This is the logic model that they created for us after listening to the 3 of us talk about our program and how it was built. And it's really been kind of a touchstone and a pillar for us to go back at every time somebody asks us, hey, do you think the camp team could do this? We look back and say, okay, how would this fit into our logic model and the goals that we are sharing for our program?
I'm gonna skip over.
Yeah, we have had the great opportunity to do some fun stuff, and we can talk about those. But
yeah, training and upskilling. Obviously, you can take a look at that list, and then this is just something, you know, every time you ask yourself, are you doing enough? And I'll let Rebecca read the quote, because this was a client that I was not involved with. This was before camp as an EMCM.
Yeah, I would say we've learned a lot as providers. We've had a deliberate arc, all of us, over years to gain the skills to do this work. And there are definitely lots of days where you witness what clients are experiencing in terms of barriers, and you think, I don't know if this is enough of an impact that we're having. And this was an unsolicited text we got from a client in the middle of the night who's given permission for us to share this with people. And this was just before she had her baby. She'd had previously multiple pregnancies where she just arrived in labor at the hospital and had accessed no care at all, and then accessed no care after. And in the pregnancy where we became involved, she accessed a full course of pregnancy care, and we remain involved with her in terms of her reproductive care even now a few years later. But she said, thank you all for everything. I can't even imagine how much harder everything would have been without all of you. I never felt shameful or judged at all. It was weird being treated like a normal human being who just needed some help at first, but I honestly feel blessed. And so that's kind of what we carry is, you know, if that's the only impact we've made, that's good enough on some days. So we will defer to the remainder of our colleagues and happy to answer questions after.
Thank you both so much. I feel like there's never enough time to get into it, but there are questions in the panel that'll probably bring some of this back up. And I think, Rebecca, you and I talked a little bit about this exact quote when we met, which I'm really grateful you put it in, because these are the kinds of things that matter so much to us when we have those days. So I'm going to move on, because we're going to hold questions for the panel. So I'm going to move on to the next group of speakers. So thank you both, Rebecca and Jill, for all of that overview. And again, it's all recorded and we'll post it to the website as well. So I just want to say welcome, Rebecca and Jenny. So if you both want to share your presentation now, we will hear from Norwest. I got to make you a co-host first. Just 1 second here. There we go.
Okay, thank you very much. Can you see the slides?
We sure can.
Okay, perfect. So just a quick introductions. My name is Jenny. I use they and she pronouns. Rebecca is here as well, she and her pronouns, and we're going to talk about the Norwest Community Health Center's midwifery program. We're starting to call it Umbrella Health, or something similar. So you may hear that term in our presentation as well. And we're located in Thunder Bay, Ontario. I think we can go to the slideshow here. Pardon me, we're just getting the slides going. There we go.
So just to do a land acknowledgement from where we're presenting, because we're up in northwestern Ontario, we live and work on the traditional and the present day territories of the Forum First Nation, which is signatory to the Robinson Superior Treaty of 1850. And we believe strongly that as midwives and researchers, we're committed to ongoing reconciliation efforts in a spirit of humility and for continuous learning. And we want to warmly invite you to contribute to our shared journey as settlers by bringing forward equity, diversity, inclusion issues for discussion and action, because your insights and perspectives are valuable in fostering a culture of learning and respect.
Thank you, Rebecca. So the midwifery program at Norwest Community Health Centers, the funding was applied for and received in 2018. And the funding application was created by a local midwife and nurse practitioner and the CEO of the community health center. And so it was very much a community initiative to bring midwives to Thunder Bay and to Northwestern Ontario specifically. Non-Indigenous midwives, there is also an Indigenous midwifery practice with some overlap in terms of services. So we were funded in 2018. Two part-time midwives offered services, Rebecca and another midwife from 2018 to 2019. I started full-time in 2020, and we've been increasing our staffing and our full-time equivalent positions since 2020. We've added services every year. We started with the comprehensive perinatal care that we were doing and added extended well baby care. And we can talk a little bit more about the details of these programs, as well as contraceptive services. And then we have also, we've been offering LARC insertions since the first year that we were funded. So currently we're funded for 4 full-time midwifery positions and 1 full-time lactation consultant.
So our services, as Jenny was saying, have increased over the last 5 years, consistently based on community needs. We started with perinatal care for folks that were having a hard time accessing services and not meeting midwifery or obstetrical care in general, mostly for prenatal and postpartum. And then we found there's long wait lists in our community for contraceptive insertions. So that's why we brought that on board. One of the local OB-GYNs who was partnering with our program agreed to do the training for the IUD insertions in 2019 and support us with a medical directive to insert them beyond the 8 weeks postpartum. And then we had our only sexual health clinic close in the middle of the pandemic. Tragically, the physician running it was killed in a motor vehicle accident. So our walk-in was experiencing an influx in referrals for all the things that the sexual health clinic was offering for point of care. So LARC insertions and abortion care, gender affirming care, and also sexual health screening and treatments. So we approached our team here, our interdisciplinary team, and presented at rounds on the ways midwives could help fill the gaps. Everyone was quite excited about it because the referral process was taking for contraception with a specialist up to 3 to 6 months, and people were returning again and again with unplanned pregnancies. So we really have expanded. We still do comprehensive prenatal care. We do postpartum care from hospital visits after birth all the way up to 18 months. So we've expanded that program. It's estimated about 40% of folks in our community have no access to primary care, no assigned primary care provider. So we're filling the gap in doing the immunizations and the well baby care until they're done their routine schedule. We do labor and birth preparation. We do gender affirming supportive care and care with the LGBT QIA plus community. Sexual health planning, screening and treatment, comprehensive abortion care, including all the medication abortion services such as point of care ultrasound, dispensing medications, and providing follow-up. And we do a lot of community outreach. And so there's a list of services or agencies in which we go out into the community to provide services. It's either for health education, drop-ins, or for clinic. We do also travel up to one of the remote communities where our CHC is affiliated and has a clinic once a month, and around the city of Thunder Bay to offer care where people are living or closer to where they're living or getting social supports.
There are several unique features about this program, and again, responding to both what we've been funded for as a program, and also about the needs in this particular community. And we overlap services with some of the other like obstetric services in the community, but we also try and again, like the previous group in Guelph, try and fill those gaps. So we are not an on-call team. However, we have tried to work in flexibility in terms of working hours, but in that we don't provide any interpartum care. We collaborate with a local obstetrician and any of her team for interpartum care, and then people get support through other services in the community, including the Indigenous midwives if they need support during labor. We work quite a bit with people from 12 to 20, age 12 to 20. Many are affected by FASD or fetal alcohol spectrum disorder. And not only the teenagers, we work with people through their reproductive years on reproductive life planning, and supporting them in their contraceptive decisions, as well as through multiple pregnancies or however they present. We do have a significant population of newcomers and refugees and new immigrants to the Thunder Bay area. And so healthcare system navigation is a huge part of our job. And we provide services to incarcerated teenagers and adults at the local facilities. And that includes any of the reproductive services, as well as perinatal care if we need to. We have a close collaboration with the Indigenous midwifery practice here in town, and also with our two local MPG practices who, for people who are needing, who are low risk and who can benefit from their care. And we work closely, sometimes seeing people collaboratively or transferring people back and forth when that's appropriate. Our program has always had a harm reduction focus, and our community health center definitely prioritizes services for people who are using drugs or who have a history of addiction. And so making sure that the care is really relevant to them, no matter who is actually receiving the care, has been a huge priority for me, for us as a team, all the way through our program. Rebecca talked a little bit about some of the remote clinics we do, and we offer now, as our team is growing, we are offering more same-day and walk-in services, especially for the abortion care or emergency contraception.
And we're getting short on time as well, so we'll just look at what are our future expansions. Our program is very nimble and seems to just develop as per what our community looks like they need and what our capacity is. So as we have more people coming on board, some of our future expansions are going to be more immediate newborn and postpartum home visiting with our new lactation consultant for people upon discharge that have no primary care provider. We're looking at housing and early pregnancy complications and loss clinic, post-emergency visits here at our CHC to be able to provide that care. And we're doing a weekly rotation between clinic, abortion, same-day, and outreach with our 3 midwives that we have now. And so you can see the list of kind of our workflow and what it looks like in a typical day for the booked non-urgent clinical care, and also for the midwives that are doing same day urgent requests and outreach. So that's our program in a nutshell.
Thank you both so much. It's really interesting to see how you've taken the work that you do and you've organized it in a way that's very similar, not to a BCC. The work is obviously different, but it's nice to see people shuffle roles around to see how you can batch your time to be a little bit more efficient and have a bit more balance. So amazing. Thank you so much. I have so many questions. So I'm going to hold them. And then what we're going to do is hear from the last presenter, and then we'll get you to come back for the panel. So thank you so much. So our last and final presenter, our last EMCM presentation before we start the panel questions, will showcase the Midwifery in Toronto Community Health Program, so the MATCH program. And Jenna Bly is going to take us through that, and then we'll be back for the panel.
Hi, everybody. Watching these other two presentations, I feel like I've done a very poor job like capturing all the details of our program because I've just been doing it for a very long time. So yeah, hopefully I went back to thinking about 2014 and just it's maybe a slightly different approach, but there are lots of other presentations out there about our program that have like all of the details listed. So yeah, anyway, that's my disclaimer. I just felt like, oh, I wasn't as thorough as I should have been. So that is a picture of some of the handouts that we have from back in 2018. This is our CHC. So I just wanted to first, I'll just introduce myself and talk about where we're situated. So my name's Jenna Bly, I use they, them pronouns. I'm one of the two co-leads for the MATCH program. MATCH stands for Midwifery and Toronto Community Health. I work and live in the city now known as Toronto, and this land is governed by the Dish with One Spoon Wampum Belt Covenant, Treaty 13, the Williams Treaty, and Treaty 19. Under those treaty obligations, I and my team understand and take very seriously our responsibilities to care for this land, its resources, and each other peaceably and with great care. I feel like protecting bodily autonomy for all people is a crucial part of my work as a midwife under my treaty obligations, and that commitment, and also the belief that all people on this land deserve access to free, low-barrier, high-quality healthcare, regardless of their reason for being here. Those two ideas really drive all of our work as a team at the MATCH program. So yeah, this is the front of our building on Queen Street East in Toronto. The idea of midwives in CHCs, I think, had certainly come and gone. I was not the first person to have that idea. Both Shazeen, who's the co-lead of our program, and I wrote papers about this idea in our third year of midwifery school. So yeah, I think the idea had come and gone. But in 2014, when I was a new registrant, I was incredibly frustrated. There were a number of kind of systems changes that had happened, and I was watching a lot of problems for my cohort. So really, like the motivation to get this funding and to work in a different way came both from my own personal desire to serve my own community, like the queer community, and also newcomers and people I saw living in the neighborhood where I was working as a midwife, but not accessing midwifery care. But I was equally really motivated by like sustainability for midwifery and taking care of each other, because I saw my cohort really struggling in the first couple of years after we graduated. Like many of us were having a hard time. So in 2014, as a new registrant midwife, I started just walking in the door. I went into several CHCs with no contacts or relationships and asked if someone would talk to me about midwifery. And I was really lucky with who came down and I was greeted with a lot of support from clinical directors at the CHCs. One of the people I met on that little tour that I took myself on was Claire Haxel, who's now a midwife and running for the NDP. She was in a leadership role at Planned Parenthood at the time, so started to build a real network of support outside midwifery, people who were saying this is a good idea, keep going. Um, After about a year of that, I'd been brainstorming and knocking on doors and was really hitting dead ends and feeling like by March 2015, I felt like this isn't going to happen. And then one of the people who I'd met on one of those door knocking missions invited me to the province-wide meeting for the CHC clinical directors. And so I got a half an hour on their agenda to pitch the idea to this huge room. It was a giant table, like maybe, I don't know, 80 people. It felt enormous. In my memory, it was a very long table. And so from that meeting, a working group formed, and four clinical directors from four CHCs came to that table to just kind of explore this idea. So we're now in 2015. And the places where we really had support from within the midwifery community at that point was from the Toronto Birth Center, which came to that table and supported the idea and said that as an institution, the TBC would support this idea of midwives kind of working outside the traditional model, and also the leadership at the Midwives Clinic of East York Don Mills. So still my chief of the midwifery department, Christy Lockhart, and that whole practice also came to that table and really supported the idea. So we wouldn't have been able to move forward without that kind of support. The barriers that we were facing in 2015 are too numerous to name. Like not least of which is that a lot of midwifery world at that time thought it was a terrible idea and shouldn't happen. There was a lot of resistance actually, and I was specifically met resistance back then, and I was a baby midwife, so I was too stupid maybe to care about how kind of reckless I was being and just really wanted to work this way. So one of the things that I just want to point to, like, because now we're in this whole new climate. I had a student say to me the other day, "Oh, I haven't decided how I want to work and what model I want to choose." And it was like, for me, it was such a mind-blowing casual comment coming from a third-year student that she just takes it for granted that she can work in all these different ways. So there is all this opportunity now, but even in that context, I think there are people who maybe have ideas that where they're going to face barriers and be told they can't do it. And so it's worth it sometimes when there are big barriers, if they're not actually blocking your way right now, to just identify them and then ignore them. So one example of that for us was the Employment Standards Act. So back in 2015, there was just it was like an albatross. There was a lot of fear around, oh, midwives can't work as employees because of the Employment Standards Act and all of the like limitations that would bring. And so as a working group at that table that met at Regent Park for 2 years, I led that working group. We met almost monthly for 2 years. And we as a group decided, yeah, we see the ESA sitting there. It's a big barrier, maybe. And the model that we want to build is within the CHC, like the key thing about a community health center in Ontario and how it has always run is that all the providers are salaried and therefore they're not motivated by volumes or time, and they all work the same way. So that nurse practitioners, physicians, nurses, chiropodists, all those people are working the same way, and we didn't want to bring midwifery into that model and have them work or be paid differently. And so we were really committed to the idea of a salaried employee model. We thought that would also give us flexibility to start to do some of this other work that we've ultimately done. And so we kind of like saw this huge barrier of this law from a different ministry, like the Ministry of Labor. It's not even the Ministry of Health. And we just kind of sat it on a shelf and ignored it. And then when we got into South Riverdale in 2018, when we were funded, our leadership just got legal advice, like, what do we do about this problem? And we were able to write a one-page addendum to our contract that we all signed that made us exempt from the ESA. So just like it's good sometimes when you're facing a lot of barriers, to just keep that in mind. We've used that strategy of like, I see you barrier and I'm going to ignore you. We've used that over and over again in the match program. And it's like, if it's not blocking your way, like even if you see it down the road and it looks huge, if it's not blocking your way right now, just keep going. So yeah, we found that to be a useful approach. This is an overview of our program. So there are now 6 midwives and a social worker. Our social worker, so it's in this picture, Tiffany Fung, Deborah, oh my God, I'm just blanking on her last name right now because we call each other by our initials. it will come to me, Andrea Luchuk, Jen Brewer, Carmi Magne, myself, and then Shazeen Suleiman. We are a salaried model. We're embedded in the CHC. We provide wraparound care. We are one of the few EMCMs with on-call funding, and we do attend labors and births, and we attend them. We've had, I think, 3 home births in 6 years, but we do attend quite a few at the TBC and at Michael Garron Hospital. We provide medication abortion up to 11 weeks, and we staff, we're coming up on 2 years of staffing the early pregnancy clinic at Michael Garron Hospital, which is really incredible work that I like a lot. You can see the numbers there. We're taking care of a lot of people without OHIP, mostly racialized people and people living in low income. That number for these are just from this past quarter, is quite low. We often are more like 50% underhoused or homeless. I'm not sure why it was so low this quarter. And then this is just some stats from the first half of our fiscal. So the birth numbers are pretty low. That's partly because we are integrating a new team member in, but we do keep them low because we're dealing with people who are pretty complex. We've been running a vaccine clinic for midwives across the community. So uninsured midwifery clients who need vaccines come through. So in the past, since April, we've seen almost 100 people just for that discrete vaccine access. We provided 123 medication abortions, which, like Jenny and Rebecca were saying, we have POCUS. We give out the medication at our clinic. And then you can see the numbers for the early pregnancy clinic are quite high. We saw over 700 people in that clinic last year, and it looks like it'll be higher if we continue on this trend. The last thing, and Megan's back, so I'll finish up, but we just talking, like picking up on the theme of kind of splitting up the work. So when we hired Carmi, who's a younger midwife, she learned all the things and was doing early pregnancy and abortion and birth, but we were feeling like the team was a bit unwieldy for everyone to be doing all the jobs, and Carmi also really wanted more birth work, and the other 4 of us are older midwives, and we're happy to kind of back off and focus more on the abortion and early pregnancy work. So it was a lot of planning and conversation, but basically when we hired Jen Brewer, we hired her letting her know that her focus would be T3, so 3rd trimester, and labor and birth and postpartum care. And so you can see here on the slide, we've just split up the work. So our team does all the 1st trimester, 2nd trimester prenatal care. So we're keeping our brains like in the prenatal world and we still do histories and physicals and all of that stuff for people coming in. And then when they're coming for weeklies, they're only seeing Jen and Carmi. So they have more of that continuity with those 2. Jen and Carmi answer all the pages for labor clients. And then the 4 of us are cycling through working community clinic, being on call to back them up. So still attending births as backup and running the early pregnancy clinic. And the drop-in clinic for vaccines. Yeah, and then in terms of like going forward, we're looking at being able to offer MVAs in the hospital and the EPC. We're about to move into a dedicated midwifery-led space outside of L&D at our hospital. So it'll be a family and newborn clinic running with the other practice, the midwives clinic, and we might help staff that as well. And then the early pregnancy clinic. So we're going to have this space that belongs to us for the first time in the hospital. And there are some procedure rooms. And so our team's really interested. Right now, it's impossible to access DNCs. And so we want people coming through for early pregnancy to be able to get that care with midwives. So we're working with the National Abortion Federation, renamed Action Abortion Care Canada. And we will hopefully be getting that training soon. I'll leave it there.
Amazing, Jenna. Thank you so much. I don't know why you led with like mine's different. I thought it was a beautiful story. I think it actually plays nicely into one of the questions I have for you. And I think there's no question that there is so much sexual and reproductive. There's so many gaps in services that are needed that the work will always be there.
Yeah.
For sure, right? So, but I think one of the things I wanted to talk about, so I'm going to get everybody to come back. So if Jenny and Rebecca could come back on, and let me just make sure I have everybody here because I want to make sure that we have everybody pinned. Okay, beautiful. And yeah, so I'm gonna ask some questions that I think because you did a great job of going over your programs. I know that we could probably have spent a whole conference day just walking through the playbook, all of the things that you do. There's no doubt that you're all doing very meaningful work. I wanted to ask a question, and again, I'm gonna just sort of direct who I'm asking first, and then feel free to jump in, if you want to add something. But I wanted to start with my first question. So that first question plays off a little bit with what you just said, Jenna. So um, the majority of people who have really big, bold ideas don't typically pursue them. So 3% of people will actually, go after something that's a pretty big idea, a bold idea. And I wanted to ask each of you why you persisted. And I know that you sort of touched on this, Jenna, a little bit, and I could feel the passion that you have around serving this population of people. But why did you all continue to build your programs in light of what probably felt like insurmountable barriers at the time? And I know, Jenna, you said it kind of ignored the barriers temporarily, but I know from time to time it probably feels like they're never going to go away. Jenna, let's start with you. What was it personally about your journey why'd you keep going?
Yeah, I mean, it was a really wild time to be trying to do this in 2014. And there really wasn't support from like a lot of the midwifery community. I heard a lot of really negative comments from older midwives. So that was really hard. And I found support and built those networks outside of midwifery. So the people that I met who are the clinical directors, they're all still important people in my life. Clara Haxel was like, it didn't work out to partner with Planned Parenthood, but she kind of stayed like some of those people that I met on those days that I just walked in the front door and said, hello, like who then came downstairs, have remained in my life and been huge supports. Um, yeah, so like I said in the presentation, like I was quite motivated to do the work that I wanted to do, and at the time there was a real job shortage. I was part of the second group of the MEP that where the class size had doubled, and there really hadn't been good planning at the other end. So when my cohort graduated, there was a extreme job shortage. And so I knew I wasn't going to have a job coming out of my NR year, and it just I don't know. If I had just walked into a job, I might have just worked caseload midwifery for 20 years and been happy. I'm not sure. But because I knew that I wasn't gonna walk into that, it forced me to think about, okay, like how do I actually want to work then? If I'm not gonna like if I can't stay here and I'm not gonna be kind of like swept into this thing and taken care of by my elders, which is how it felt to me at the time, like I'm not being taken care of. So then fine, like I've got to figure this out for myself and what do I want? And I had wanted to be part of a CHC ever since I saw one during our social and cultural class in my first year. Like I remember sitting in that waiting room and being like, this is it. Like this is the thing. Why aren't we doing this? So I really like I had had that idea for my whole time through school. And then the other part of it that made me keep going was that in my cohort, like people were leaving midwifery. Like I had friends who I'd gone to school with who were calling me crying, who we didn't have stability. People, didn't have job security. There was a lot that was really hard at that time. It was a huge transition. It was the first time that there were more midwives with less than 5 years experience than the other way around. So it was like this big demographic shift in the province. And it was just kind of as a baby in that landscape, like it felt pretty chaotic. And I watched a lot of people like either leave the profession or get hurt. And so that was the thing that kept me going, I think, was just like I wanted to take care of myself, but I also really wanted to take care of the people that I loved and saw struggling. And like yeah, I'm really lucky. Like I mean, Jill and I went to school together, and I met Jenny was the first person that I ever met who said the word midwifery to me in a modern context. We just had friends in common. I met them like years ago. And Tiffany and Shazine and I went to school together. And so it like I have been able to feels like my cohort has like been taken care of much better than we were 10 years ago. And that feels really satisfying. It's not just the work, but like also the midwifery, like the ability to care for each other. Like we have someone on my team who just had a death in the family and she's like, I think I have to leave the country for this funeral. And we're like, yeah, that's fine. We can, like, we have the infrastructure to figure that out. And that's what I really wanted that as much as I wanted to do this social justice work, which I care about a lot, but I really care about us and like us getting paid to do that hard work and having the proper retirement and employment protections and all of that stuff. So I'm really glad to be an employee. Like, I know it was a huge leap for a lot of midwives, but we have not given up our autonomy and we have a lot of protections that I'm really grateful for.
Thank you. Yeah, it's a common thread around you can't really serve the clients or the patients very well unless we take care of the midwives. That seems to be a pretty obvious thing that's very hard to implement in some places, but I completely agree. I'm gonna move next to Rebecca and Jill, because Rebecca, you said something when we spoke about what, like, how you built the program, when it started and how you got off the ground, and what like on the ground level, how you were able to get it off the ground. And we were talking a bit about like the build of the program and how hard building a program actually is and what that work actually looks like. Because it's one thing to fill out an application, but I want to ask you what those things are that you said were very important in building actually getting it off the ground.
Well, I hope I answer it the same way. That's okay
if you don't.
Yeah, you can feel free to remind me of things I may have said, but I would say like like I was very lucky in terms of timing, even though I had a lot of insecurity coming through in terms of I did land in a practice where I stayed for 20 years, which was an incredible like incubation for me clinically, and had a lot of support to start doing this work. So like for me, the inception of our program started when the government was going to dismantle LINs and start building OHTs, and they sort of said like, here, communities, like build whatever you want, and we're going to take away all the existing infrastructure, and you guys figure that out. And I went to the first kind of provider meeting, and our local OHT, like they were very specific at the time. You had to define your population you were going to serve. And the OHT said, we're going to serve people with complex mental health and addictions. And so I put my hand up at the meeting. I said, so what's our plan for reproductive care for our priority population? And they went, we're going to deal with reproductive care and obstetrics later. And I went, I'm pretty sure some of those people have uteruses today and probably might need some help with that. And really just got like dismissed as like, this is a project for later. And so I just called friends who I knew were working in community organizations and said, like, could we just meet for coffee and talk about what gaps you're seeing? Like, I want some support to bring to this next meeting to show that reproductive care should be incorporated. And had some really lovely conversations where the frontline staff said 100%, this is a thing that like current systems aren't meeting. And I met with one person from an incredible CHC, the Sanguine CHC, which is a Hep C focused CHC in our region. I met with their outreach nurse, and we had coffee, and the next day she called me and she said, see, this was a good thing we talked. I have someone in my office right now who's just told me they're 28 weeks pregnant. They have really insecure housing. They're using lots of substances and street supply only, and can you come right now? And so I just went right then and did a prenatal visit and developed quite a mentorship relationship, both actually with that nurse and then also with that client. And we just took that client on as a BCC. It was certainly not well compensated work for BCC midwifery. And like I often joke, like I bought a lot of chicken nuggets to get things done for that person. Like feeding her was a really important part of her care. And my colleagues were like, I can't believe you just like keep spending all that money on her. I was like, this is my tuition. Like I'm learning so much from this person. And I still remain connected to her. Like when I went to visit her mom the other day. Just anyway, that was a long arc that really demonstrated to me both that the need was there, that the hospital infrastructures weren't there. And I had known that, but I saw the gaps. And I remember caring for her, getting ready for her C-section, and speaking with our chief of staff about the care that she'd received in the hospital through a hospitalization, and said, like, we really need an addictions team in our hospital. We need education and mentorship, and got quite a dismissive response. And I was like, yeah, if nobody else is gonna take this fight on for these clients. And then, then that's when we moved into like getting more referrals like that. And then when Schedule Q became kind of a viable option, we applied for Schedule Q funding. And we deliberately recruited people who were to our practice group that were interested in starting to build that work. And then, we applied for an EMCM and didn't get it. And then we applied for an EMCM and we did, but it was, and I would say my colleagues had done that arc of training before they actually even came to midwifery. And for me, it was definitely part of my clinical practice that led me to do that work. So, and then the opening up of funding through the OH team is why we have a program here. And we're now part of the CHC's based funding, which is not something we really would have imagined would happen, honestly. And yeah, feel really kind of inspired to build the strongest program we can with that, like, good luck and timing.
Yeah, I feel like the good luck and timing might be one thing, but also like all the social capital you built going into that would have been probably the foundation upon which the luck was placed on, right?
Yeah, like I would say for us, like I don't know, like the Sanguine team runs the community health outreach van that we just attended with no kind of like formal need to go, and we help hand out harm reduction supplies, and we help hand out things, and we just get to know the people in community. And we've had a number of people who come to us for some reproductive care, and they say, oh yeah, like, the women in my camp told me it was safe to come to you. And I don't know that we would have had the success of the program if we hadn't volunteered kind of our time to do that work for so many years, and then be trusted by the outreach workers who are trusted by the community, and ultimately trusted by a few key people in the community who then refer people to us or vouch for us when someone suggests us.
Yeah. Do you want to add anything, Jill?
It's hard to add anything. Rebecca was very, very fulsome, so we can move on.
Very articulate. And also Jenna just wrote like relationships in the chat, which is actually primarily what Rebecca and I talked about when we first spoke about this. And I think there's this sort of question in midwifery, and I see this all the time, where it's like, well, if someone's going to compensate me to create the program and build it, then I'll do it. But also, so much is not compensated until you can pilot and proof of concept it to show that there's actually a benefit to it, which is so difficult. And I think that's why so many people are like, I don't have capacity to do this. So I'm going to move to Rebecca and Jenny for the next question. I wanted to ask, and you're all free to answer this as well. I wanted to ask, Rebecca, you wrote me back and you said something that I thought was really great. And so the question I asked you was, how does this work, these roles that you both do, how do they impact you as a human being, as a person, not necessarily as like a clinician with the data and the metrics assigned to what the value of the program, but as a person? And it can be, sustainability based, it can be very fulfilling. How would you articulate that, both of you?
Yeah, there's a lot of impact. I mean, part of it is this relationship building. I've been studying sort of midwifery integration into primary care with other midwives and with other care providers. And it really reflects my personal experience as just feeling valued in the healthcare system and filling these needs that we see in midwifery clinics that we're not able to fill because of the restrictions put on us, through our legislation and regulations. And so it's been really, affirming as a midwife with lots of skills to be able to work in a place that values those skills and is looking forward to you offering even more. And then on the flip side, the clients we're working with, you can just see that by increasing access and building relationships and offering more continuity and offering care beyond a very limited time period in their lives, they continue to return for other healthcare needs. And it just feels really, really great as a provider with lots of different skills to offer, to be able to offer them in many ways. Like to say, yeah, I mean, it sounds hilarious, but I had a visit today with someone who was 66, as we do cervical screening throughout the entire lifespan. And this person had all these questions about pleasure and anatomy, and I was able to kind of answer some of them based on, knowing what pap tests and using smaller speculums. And we have people coming in for abortion care that have lots of questions on contraception and just dispelling myths on what's safe and appropriate and really finding what works for them. It's really midwifery based, the model of care. And as a midwife, I mean, I choose to be a midwife because I believe in that model of care and providing people with those services in that way. It's great. It just really, it feels like freedom to be able to offer more care. And I really see the impact in our community. And many communities are underserved, so we're not unique. Yeah.
Yeah, I think I would agree. It's being in a multidisciplinary setting and having these like very equal footing collaborative relationships for the first time, I feel like is very healing. I started as a midwife in 2006 in a really hostile hospital setting. And so we had to go into multiple hospitals where the other providers were, and some of the nursing staff were really hostile to us. And so we were as a group trying to navigate that. And then I worked in the States for almost 10 years and also had some of that antagonistic relationships with people we were transferring care to. And so then really when I looked for this job, I was looking for a different way of working where I would be compensated for doing all these other things that I had learned and taught myself and my colleagues. As a genderqueer person, I wanted something that would validate where I could really be my whole self at my work with my colleagues. And I have found that, especially with the nurse practitioners and family doctors here at this center, it's incredible the relationships. And I did do it very deliberately. My first 6 months here, I spent many days just hanging out with different people in different services and building, and like Jenna said, and like Rebecca and Jill, like building those relationships and showing where my experience, but also being really collegial and like being curious about how people were doing their jobs, how these outreach workers were getting to people, getting people in for care. And so that whole piece. The other thing that I would say is being able, when we started providing abortions, rather than just doing abortion counseling, which is what we had done initially in the program, it was so wonderful to have that continuity across multiple pregnancies. And so just being able to be in all of those spaces with people. And now we've had people who've had 4 or 5 pregnancies, like in the 5 years that I've been here, with different outcomes and different experiences and different, potentially even different partners or different relationships. And we can be the constant, our team can be the constant for them. And even beyond primary care, like it's not, their primary care providers are really important to them as well, but being able to be really specialist in their reproductive care across those multiple experiences, that's what's the most validating for me. 100%.
Very well put. It was wonderful. Did Jenna, Rebecca, or Jill, do you have anything you want to add to that like how it impacts you as a person? The role? No, you guys.
I mean, I agree with everything Jenny said, and I remember going to South Riverdale for the first time. I started shadowing one of the NPs who was offering some prenatal care at the time back in 2017. And I remember going and feeling like, oh, I'm gonna work in a real medical clinic. Like I really had that imposter syndrome and like sense, yeah, of like real medicine happens and like midwifery is this other thing. And it's just there's been a complete flip like what Jenny just described it really well. But um, first of all, like I mean, we are specialists. And so in the primary care setting, they're all generalists. And I like bow to their wide breadth of knowledge. But when it comes to pregnancy, we know way more. Like our training is we have so much more depth of training. And so it took a couple years, but it was so obvious that even the people like there were a couple people who had been doing some of that prenatal work and they were a little bit more protective on the clinical floor when we first came. But it like our expertise and skill just is so glaringly obvious that it very quickly switched. And, if you had told me 10 years ago, like the idea that physicians would use the language of consult and speak to midwives, but I think all of us have had that happen at this point. Like that's very routine now to have a physician walk into my clinic room and ask for a consult. It's also translated to our OBs, and we were lucky, we had good relationships at our hospital already, but when we started doing, especially we spent a couple years, like during the pandemic, we really filled in and did a lot of substance use and pregnancy work because one of the main clinics in downtown Toronto closed for a time, and we just like filled that gap again, like that nimbleness of the program. Like we're not doing much of that work now because that clinic reopened and they're better equipped. But anyway, we built a lot of skill and did a lot of that work for a couple of years, and our OBs immediately recognized that we knew more than them about this stuff and started referring people to us. So we've had obstetricians like give us their patients, like take people into care and be like, actually, they'd be better served with you. I've had OBs like call for a consult about things like domestic violence. Like, can you help me? I have someone in my office. Can you help me navigate this? And we have the skills and protocols and plans for all of that. And so we can. So we've really just seen like being recognized as experts and as having a special skill set that even our surgeon colleagues have now recognized. Like it feels so good. And I really feel like, yeah, like we're experts. And that is very clear, like in the bigger system when you're working in this way.
Absolutely. And I think what you're touching on, Jenna, too, is like this, it's like the gender bias that exists in the healthcare system is so pervasive that it's literally the way it's what we're dealing with every day that we don't always recognize. So even just talking about, Rebecca, you going to the chief of staff and being met with this sort of dismissive reaction, that's very, very typical because like, women and birthing people's healthcare has never really been a priority. So it's interesting as when I watch you all build your programs and you're talking about building your programs, what you're actually doing is creating a new model that prioritizes people with a uterus and people who have need very specific skills. And when we've dumped that work predominantly on obstetricians and gynecologists for 200 years, there's no capacity for people to do a really good job of it. So that's probably why it feels so hard, is like you're creating something new, right? Which is so needed. And I love that each of you across the lifespan is treating there's different touch points where you're able to provide a gender equity lens and prioritize people with the actual issues that person has, which is where I think we see such high satisfaction levels because people are being treated like human beings, not like just another thing that comes in, right? So I appreciate all of your time. I could talk to you for hours. I know Nikki Mills posted in the chat. She works here in London as a nurse practitioner and a midwife, and she has an expanded scope as well in both roles, and was just commenting and commending all of you for all of the work you've done because it's so liberating to be able to serve in your fullest scope and your fullest breadth of your skill set. So thank you all for all your time today. We're going to move on to the next and the final chat for the day. So if you have any questions for the panelists, please feel free in the chat to continue messaging, because I know this is sort of the start of, I'm sure, a lot of people's interests in building programs. So our next speakers, I'm just going to pull this up here. So, like I said, to finish off the second of our 3-day conference, we will have a program showcase on group care innovation and sustainability. So, the presenters for this talk will be Rebecca Crone and Sojourner San Vincent. We'll put your bios in the chat, so you're welcome. You're here. I see you both. I'm just gonna get the screen organized here. And then you guys are free to share your slides. I'm just going to make you both co-hosts so that whoever is going to share their slides. So welcome, both of you. I think you can go ahead and share now.
Great. Hi, everybody. So welcome. Thank you for hanging on to the end with us for our presentation. My name is Rebecca Crone. This is my colleague, Sojourner San Vicente, and we are two of the midwives that work out of, which is now Oak Valley Health, which used to be Markham Stouffville Hospital. And we are spearheading the new group pregnancy program, which is basically a model of group care that does antenatal and postpartum care in a group setting. So we're going to be talking a little bit about that with you guys today.
So today we'll be sharing some information about the setting and model within which we work. We'll talk a little bit about the structure and the benefits of group care, and then also about the work that we've done so far and the upcoming next steps. Just beginning with locating ourselves. The group pregnancy program, as Rebecca mentioned, is being launched at Markham Stouffville Hospital, which is now Oak Valley Health. And it's in the Alongside Midwifery unit. And Markham, for those of you who don't know, is just a suburb to the northeast of Toronto. Oak Valley Health is located on the traditional lands of the Haudenosaunee, Huron-Wendat, Anishinaabe, Seneca, Chippewa, and the Mississaugas of the Credit. The Alongside Midwifery Unit opened its doors in 2018, led by midwife Carol Cameron, and it's an expanded midwifery care model, as many of you know, meaning that it operates outside of the traditional community clinic care-based model.
So, sorry, I was muted. We have a number of programs that run out of Oak Valley Health. And before I kind of go through those, I also just wanted to touch on that we are also an employee-based model as well. So we're not based on caseload. I don't know if that was anywhere else in our presentation. So just wanted to mention that, kind of tagging along on Jenna's presentation before. So the Alongside Midwifery unit is a fully standalone midwifery unit, and it occupies its own wing of the hospital, which is just adjacent, so just down the hall from labor and delivery. So the entire 4th floor at Oak Valley Health is mostly labor and delivery, the Alongside Midwifery unit and postpartum. So everything is on that level. And so many of you are probably familiar with how a hospitalist model midwife sort of works. So one of the programs that we have that started there was the hospitalist model, where midwives working out in the community will have privileges at Oak Valley Health, and they will send their clients in, and when the hospital is available, they will do early labor triages, decrease fetal movement, preterm labor, anything really that most community midwives would kind of meet their clients in the hospital for. They also are the second midwife or the backup midwife for those births as well. So most of the community midwives don't do backups in the hospital unless for some reason acuity doesn't allow that. They also will initiate inductions for the community midwives. They will take their pages overnight, and they also often will help liaise between our unit and the obstetrics. So rather than you having to sometimes worry about being with your client and also speaking with the OB, if you sort of update the hospitalist on what's going on, they can often facilitate that consult for you and sort of get that going while you're figuring out what else you need to do. The hospitalist midwives also support the obstetrical patients on the obstetrical side with C-section surgical assists. Most of us also conduct deliveries and do patient care when we're needed over there and when we're not busy on our side. So often we'll get a call, like lots of other midwives do, that the OB is in a C-section and somebody's delivering, or can we come over and do a newborn exam? And so many of the hospitalists have their C-section assistants, so do some of us in our program as well. One of the other programs that also exists on the unit is called the Family and Baby Clinic. And so this clinic is a midwife-led postpartum clinic for obstetrical patients who aren't able to see their family doctor, don't have a family doctor, who are eligible for early discharge. They're able to have that as well. And so they will get that day one visit if they go home, and then they will come to the hospital to have all the routine newborn assessments done. So they will have their bilirubin, their weight check, feeding assistant, any kind of support like that, any consults that need to be done if they need to initiate phototherapy, the midwives will initiate that and follow up. And they also are able to come up until 4 weeks postpartum in that program.
So, as with many innovations, the idea for group care was proposed to meet some system gaps and community needs. On an organizational level, we wanted to reduce the amount of rejections that were being received for primary care referrals for pregnancy, also increase public usage of the AMU, and also have a greater representation of the community surrounding the AMU or surrounding Markham Civil Hospital use the AMU and be in midwifery care themselves too. Also, it provides another opportunities for midwives to work in an alternative model of care. So, for example, we aren't on call and we work in a shift-based model of 8 to 12-hour shifts. The program also supports integration between L&D and the AMU, as Rebecca just mentioned, to support those collaborative relationships as well.
So definitely don't expect everybody to be able to go through this whole slide. Also, I recognize the font is extremely tiny. So it's just an example to show you like a high level overview of one of the examples in which we sort of collaborated with the other departments in order to meet the needs of our new program of the AMU. So we call this our surge plan. So for example, at the moment, in our hospital, we currently have one hospitalist staffed 24/7, which has always been there. And then our program, because our program is actually in-house on the AMU, so like our clinic is on the AMU, we are on the floor all the time. And so one of us is also staffed there 24/7. But we also have, like we've just started in April, May, and we only started taking clients, I think, in July, August, and we're already full for almost every single month going forward. So we're taking almost up to 20 people a month, which is normal for most community practices. But when there's only one person on call, or one person on the floor at a time, you can imagine that there will be times where 2 people or 5 people are all going to be in labor at the same time. So trying to figure out like how to maintain as much continuity as we can for those clients, those patients was really important. So we developed this surge plan. So we developed this plan with the midwives, the nurses, the OBs, the clinical leads, how to sort of safely figure out what to do with people if we have more than acuity allows. So as you go down the list, of course, we're going to first assess like, are we safely able to manage this with the number of midwives we have on the floor between the hospitalist midwife and the MP program midwife? Can we keep these 2 or 3 people? Is somebody about to be discharged? Is somebody only coming in for a triage? Or do we have like a number of people that are in active labor and we really aren't able to kind of safely to manage it? So if I'm just looking at, just different notes that were here. So the decisions can range anywhere from basically who is caring for which patients to do we have extra midwives on the floor? Is it only a few hours? Is somebody able to come in? Or do we have to completely transfer people to the other side? And it is possible that currently, as the program is ramping up, that if we have to transfer people over to the other side, that their care for that time would be transferred to obstetrical care. And then when we were free, after finishing with our person on our side, if we're able to, we would come over and either do supportive care, and then we would resume all postpartum care per normal.
And I have to say, it's been really awesome. Oh, sorry, the level of collaboration from somebody coming from an MPG where I wasn't so much at meetings with nurses and OBs. It's been really cool to see how on board everybody has been and how supportive they've been with this surge plan.
So this is the general structure of what the group care would look like. So currently, because we're a new program, we're still doing one-to-one care, sort of like your typical midwifery model. But the idea eventually is to move into group care. So the main difference would be that we are shifting from like that typical sort of 30-minute one-to-one appointment to group sessions, which would typically run between 1 to 2 hours in length. So in each group, there would be a variety of topics relevant to the gestation of that group. So if, for example, we had a group of people that were between 20 and 24 weeks pregnant, then the discussion topics would be related to that gestation. Whereas if we had people who were, 36 weeks pregnant around that time, that those topics and those activities would look much different. And so additionally, on top of the group session, there is also short one-to-one time for each client to go over their vitals, to do position checks, fundal assessments, and review any outstanding results. The idea, though, is to try to make people as independent as possible. So they will, learn to take their own blood pressure, and if they want to track, they'll self-weigh and keep track of their own results in a journal and report them to the midwife when they come in. So rather than us saying like us doing their blood pressure, and we're just really trying to get them involved in their own health care. So the patients, the clients will be seen in groups of 8 to 10, facilitated by 2 midwives. So the idea is that the structure of the program is really group led. So rather than it being a 1 to 2 hour session where one midwife is standing in front of you, giving you all the information, the job of the midwife is really to help facilitate that discussion and get also suggestions from the group as far as how to find that information. So, for example, if somebody asked like, well, what is the normal blood pressure? So rather than just telling them what it is, we would say, okay, well, who here has ideas about like what might a normal blood pressure be? If we don't know, where is a reliable place that we might be able to find that? Where is a not so reliable place that we might be able to find that? And then just really engage the group in that discussion, which will facilitate not only, again, them learning how to find reliable resources, but also building a sense of community. So it's less like a teacher model where the teacher is holding all of the knowledge. It's more of kind of like a student-led group. And of course, we will give them the answer. We will say, well, a normal blood pressure should be this. And, that answer will come out, but it's really to kind of encourage that discussion. And as mentioned, so it's a shared care model. So again, rather than them seeing kind of 1 or 2 midwives all the way through, we're a team of 5 full-time midwives. And the way that we have structured our program is that certain midwives mostly do clinic. I only do intrapartum shifts, for example. So I'm not doing clinic unless for some reason the clinic midwife calls in sick and there's no one else and I happen to be there. But I only do intrapartum, so I'm not doing home visits either. I'm there on the floor, and I will do triages, answer pages, deliveries, the recovery and all of that while I'm there on the floor. As we also sort of mentioned, we're really well integrated into the hospital. So the midwives attend rounds, they collaborate well with nursing staff, with the OBs, the hospitalists, doing first assist, providing newborn exams if there are people who want to leave early. And if for some reason we are short on the floor, the nurses are also staffed to come over and help us if we need a baby nurse, if we're busy on our side.
Here we've just grouped some of the benefits of group care. So for clients, of course, we've touched on the really big one is sense of community building and shared learning and bringing diverse perspectives together. While facilitated by a midwife, really the emphasis is on client discussion and idea sharing and tip sharing, hopefully multips learning from primates and people from different backgrounds sharing information together. We're also really excited because I think especially since COVID, people still are feeling quite isolated. So I know in my experience so far doing clinic appointments, when I bring up the idea of group care, to incoming clients, they seem really excited about the opportunity, including people who've had babies before. They're excited to share the things that they've learned and still learn things along with the group as well. Clients, like Rebecca said, they also benefit from some one-to-one time with the midwife. So closer to one's due date, or if they're sharing of sensitive results, then they have the opportunity to speak one-to-one with one of the midwives to facilitate those discussions. Also, of course, group care provides a different model for midwives themselves. And we're hoping that as more and more sustainable models become available, that people have more options that they can choose from so that they can remain in the profession and keep the parts of midwifery that they love. So our program being one example, like Rebecca touched on, we work in a shift-based model. So either an 8-hour or a 12-hour shift. Usually it aligns with the 12-hour shifts align with the hospitalist shift. So you're kind of paired with them for your shift. And the schedule kind of values midwives' input. So we all get to kind of contribute to the making of the schedule with our preferences for how that it's modeled. As employees, we also benefit from things like sick days and like the HOOP program, so the Healthcare of Ontario Pension Program for healthcare workers. And like Rebecca mentioned too, there's flexibilities in terms of our role. So I do both clinic, for example, and home visits and intrapartum care, which I enjoy and got to participate and influence the decision making to kind of take on those roles. And then one of the things that really stood out to us in terms of care model improvements. So we got the privilege of being trained by a midwife named Jelana from the States through the group Centering Pregnancy. And she really, I think, sold group care to us in a really positive way. One of the things that came up that people felt a little tired from, I think, from the quote unquote traditional model of care is like redundancy. So instead of now having, 8 talks about GDM, you can have one talk in a kind of 2-hour or more facilitated session, and really hopefully gain perspectives, gain more information, and make that time most efficient with people too, rather than, for example, maybe rushing through the topic because of different parameters. Okay, so to date, like Rebecca mentioned too, our program launched in May/April. So we're still kind of in the growing stages of development of laying the foundation for group care. We've assembled the midwifery team and engaged in the training that I spoke about. We've also begun taking clients into care, and we plan to start with postpartum group sessions in early 2025. We also led a series of community co-facilitation sessions. So the call went out to different staff at our hospital, physicians, nurses, volunteers, and was also promoted to the community at large for people wanting to give their input about how group care should be structured. And so those were really awesome. We had 2 of those in May or June. And gathered participants' feedback about their own journeys, through healthcare systems as new parents, and what they would have wanted for their care. Lastly, we were able to leverage the diverse expertise amongst those people who attended those sessions. So we have the foundation for an expert advisory panel who we hope to create to help with program evaluation. In terms of upcoming next steps, there will be the launching of the postnatal and the prenatal group care. So again, in 2025, we've begun recruiting additional staff to help with some of the scheduling gaps that we have. So people are welcome to apply for casual shifts as part of our program. There's going to be the solidifying of members for that expert advisory panel for program evaluation, and then ongoing evaluation so that we can make sure that the program is reflecting the needs of our clients.
So these are the 5 full-time midwives that have started in the group. As Sojourner mentioned, we are also hiring a number of casual to fill shifts here and there. So if you're looking to pick up a shift, try something new, you can come apply. And if you need to get a hold of us, or if you know anybody that lives in the area that is interested, they can self-refer on the website. So just midwifery program at oakvalleyhealth.ca.
I should also too just give a shout out to Abby, who is our former manager, who really helped lay the groundwork for having us funded and everything getting going for group care. And also Ginny Brunton, who is a prof at Ontario Tech University, who's helped a lot with the research background for this uh, group care program as well.
Thank you both so much for this. This is, it's funny, this is something that I've been talking to some of my colleagues about recently. And we were just talking about this exact sort of piece about inefficiency, feeling kind of like there's 5 people going in 5 different directions, and feeling like it could maybe be a little bit more structured as far as how we're offering services. So thank you both for that. So feel free to place questions in the Q&A. I have a number of questions for both of you because it's such a cool program. I wanted to ask if you could walk us through like what a typical week would look like clinic wise, because I always think about if you're booking, if or what it will look like if you're booking 8 to 10 people at once. What are you offering for availability, and then how do you kind of structure the onboarding of that process with like confidentiality, and how do you navigate that, or how do you plan to navigate that?
I think we're totally still in the like initial stages of figuring that out, which is a good thing. So if people have suggestions, that's great. We also, through our training with centering pregnancy, they gave us a template of like what they do in terms of intakes and what weeks that they like group people by and how they decide to do that. And it's a lot of like organization and math. So it's great to have a template to go based off of. Because of the balance of having, we have usually like a what's called a float midwife on the unit. At the same time as the clinic midwife. And so having two kind of helps us to any kind of confidentiality pieces and to find out people's preferences about like what they're comfortable with in a group setting. So, for example, one of the questions that we asked at the co-facilitation sessions is how do people feel about people bringing partners or other people being in the room? And so, having two midwives available kind of helps to get some of that information that people might not want to share in a larger setting, to help us influence how we will structure the larger sessions. And they can be difference between cohorts too. So, one group might be really into one thing that a different group kind of unanimously decides that they're not into, and that's okay too.
Perfect. And so are these cohorts in like they don't really they don't change. So it's the same amount, same people every time they meet, correct?
Yes, exactly.
Okay.
Yeah, all the way to 6 weeks postpartum. So then you can see people who have like you went through together and now you're all having your babies together, and it's almost like a mommy or like a parent and me group like by the end, right? So
And what a great way to build confidence in being a parent within the healthcare system, to advocate and ask questions and take your own blood pressure. I think that's really, really cool. Lauren just asked, she just said in the chat, I would love it if you could share any details about space, like where you will hold the group prenatal sessions, how you were able to even find physical space to do it, and how you provide some privacy for the checks despite having partners or other children present. And I was wondering the same thing around, are the one-to-one pieces done first and then the group meets, or is it kind of in throughout? So yeah, space and kind of privacy.
yeah, this part was actually really interesting because like we all had the same questions, because I think our typical model of midwifery care, it's like extremely private. It's just you and your midwife. You have 30 minutes. It's like a little fair, like it's just the two of you. So we are fortunate enough that at our particular hospital, we have our own wing, like our own entire unit. So that's not just like we have a room, like the whole unit is just midwives. Like there are times where postpartum might need to surge, which lent us the opportunity to be able to use different spaces. So for example, prior to even like the family and baby clinic running out of there, and prior to our program, we had like a big, room that was like our conference room. And so that room is now our clinic space. So we ordered all the equipment, we put it in that clinic space, and that room is quite large. And there are other spaces in the hospital if we did need to use like a separate conference room. So as far as space, like we've just been really fortunate that like the alongside midwifery unit, like it's like I said, it's just like our own unit there. I think on the unit there are 12, 13, 14 rooms. So like it's quite a lot of space. The one-to-one privacy issue, this is the part that was super interesting. So when we were being taught it, so like everything happens in a group setting, all of the conversations, and actually what they did for the checks and all that, they just pulled the client like aside to a separate part of the room, not behind a barrier, not behind anything, because the idea was that like if you're putting somebody behind a barrier, people are kind of like more interested in what's going on there, and they're wondering like what is going on. And there is also always space for people who, if they really have a confidential issue, to have time either afterwards to somehow communicate that to us. I mean, the minutia of all those details, again, yet to be figured out, but there will be space for that. So there's no like vaginal exams happening in front of everybody. That would be done separately. But again, like going over results, if they're normal, that is happening. Like if I'm on this side of the room, that's happening over there on that side of the room, right? So everyone just kind of does their own thing, and then that's just kind of happening over there.
Really cool. That's awesome. And there was something else I was going to ask you. Carlene just said in pelvic exams, there can be a room or screens in centering pregnancy care. So that's amazing. So interesting. So you probably don't have the details yet as to how much blocks of time you're going to book for this just yet, because we're not sure how long it's going to go, right?
For
Yeah,
each group or
Yeah.
for
Yeah, like if you were to schedule like one group that day, if it would be a window period of time, you would give the midwives to do the whole thing plus any one-to-ones.
yeah. I think the most participants in our co-facilitation sessions thought that like I think it was like an hour and a half to 2 hours was the max that they would like to be in an appointment for and take time off of work for. So I think they will probably run longer as we like are figuring out the kinks and getting our like, the topics like all fleshed out. But we're aiming to as we, want to be more efficient to aim for that timeline to respect other people's time
I
as
think with
well.
maybe like one session in the morning and one in the afternoon. I think that's what we were.
Cool.
Yeah.
It's nice too for the people who want to be quick. They repeat midwifery clients and they want to come in and just kind of do their thing, and then because they know all the content, so it gives a bit of flexibility that way. Okay, I think we have time for one more question. I wanted to ask you, I have so many questions, so I'll probably follow up. I wanted to ask if the centering pregnancy care had any recommendations or how you would establish like a safe or a brave space for everybody that's attending. Is there a clear set of recommendations around how you would establish like the expectations for this space?
It was I feel like one of the things that stood out to me that Jelana had stressed, it was kind of a lot like camp, the kind of structure of how things went. So like making a group kind of charter that we all agree to. But it definitely like puts us responsible for like within ourselves practicing those facilitation techniques for if challenging things come up, or making sure that like people have equal chance of being able to share, and how do we navigate like people who might take over the group or have like when we have conversations about vaccinations or circumcision and those things. One of the things I feel like Jelana really impressed upon us is trust the group, which I think as people used to being the facilitator in a one-on-one clinic appointment is hard to let go of. But she gave us a lot of examples that I felt provided reassurance, and knowing that sometimes things are going to feel awkward and you're going to have to learn how you're going to navigate that. But just as you do in normal clinical practice, when somebody says something and somebody else is in the room and you're trying to navigate that situation as well. But she did provide some like tangible techniques that we can use to kind of like create a space that people feel comfortable sharing. And I think that will come with time too. And that's one of the benefits of the group remaining in the same cohort, is that hopefully without like people changing here and there, then they develop like a better sense of relationships with one another. And then that carries through. And she seemed to suggest that a lot of people carry those conversations like, with WhatsApp groups or whatever outside of outside of the appointment time. And so there's lots of additional relationship building that's happening, not just in the clinic space, which is really positive too.
And I think like to touch like just to follow on that, like it that will come with time because when we would sort of did mock examples of, for example, a participant that said something slightly that the group might consider inflammatory or kept jumping in when it was like not their turn. Like Jelena did a really good example of like deflecting like what that person sort of said and did and like bringing it back to the group and being able to. So I think like that it's because she has been doing it for so long that there was really like no, we did examples where she was like, okay, pretend to be, ask a question. And like midwives, we were being like so difficult. We gave her like the hardest question. Like we just all were, and she did a really good job at kind of like putting it back onto the group and kind of like containing that facilitation. And so I think that will just come with time and skill. Yeah.
Amazing. Well, you are doing really great work. I hope, again, somebody will come out and fund an evaluation of this because it's I think it's going to be really important work. So thank you both for coming today. Thanks to everyone who's come today. So right now, basically, we're done, but this will sort of be the end of our conference for the second day. I just want to take a second before we all go just to thank the speakers for their fantastic and informative presentations. I know that there are many more programs being offered by midwives throughout Ontario. I look forward to you showcasing them every year. We send a call out for abstracts or presentation pitches. So please let us know. We'd love to give you a platform to share your knowledge. I'd love it if everybody could just take a quick moment to fill out our survey. The QR code should be right there for you to scan. It's really short, but it does help us. We do use the feedback to plan for the following year's conference. There's also a fund that's been set up in the name of late Jane Erdman, who was a local midwife here in London, who was a gift to many clients and midwives locally and provincially. The fund supports the midwifery work that we do here in London, and it supports conferences like this. So if you wish to support and donate to the fund, you can visit the website through the QR code. I just want to send a final reminder for the last day of the conference, which is tomorrow. We're going to be highlighting all aspects of midwifery leadership. Dr. Chantel Thorne will be our keynote address. She will be talking about building a thriving MPG culture. Claire Ram-Logan-Salenga and Abby Corbin will offer a spotlight on their experiences and some of the information they have around experiences of racialized leaders. And then we're going to close with a panel discussion on Indigenous leadership in midwifery and reproductive health. So I hope you will all join us tomorrow for this great conversation. And if you want to reach out and connect further, please don't hesitate. Have a good day.